All right, so we might be holding actually at a pretty steady number now. If we're feeling okay to go ahead and get started. Um, so welcome everyone to the poster session for evaluating the effectiveness and or quality of digital tools. I'm very excited for all of our poster presenters and what we get to learn and hear from today. So we'll go in order. Our poster presenters will have 2 to 3 minutes, I would say, to present since we have that smaller number, and then we'll have 3 minutes for questions. Folks are welcome to chat questions throughout, either to the main session, or if you want to chat it just to me as well, I'm happy to ask those questions on behalf of people at the end of each individual presenter. And also, you're more than welcome to unmute after the presenter has gone to ask your questions out loud as well. So whatever feels best to people. We're excited to get some questions and hear more after the posters are presented. So Kanza, I will let you go ahead and introduce yourself and present.
Thank you, Anna. Good afternoon, everyone. I'm Kanza Faisal. I'm a PhD candidate, and today I'll be presenting you a poster from my PhD dissertation. I think the slides are visible, right?
Yes, we can see it. Perfect.
Great. So we conducted a study on exploring factors that kind of influence the patient satisfaction in lower middle income countries like Pakistan. It was an exploratory sequential mixed method study design to explore patient satisfaction with guided ICBT for mild to moderate depression. The age range for participants was 18 to 45. In the first phase, a qualitative study was conducted from 10 patients who had completed guided ICBT through semi-structured interviews via Zoom. Patients identified a few clinical factors like like therapist expertise, engagement in treatment personalization, alignment with patient expectations, strength of the therapeutic relationship, and reflective feedback as key factors influencing their satisfaction with guided ICBT. And some of the non-clinical factors that were emerged from the data through thematic analysis were accessibility, flexibility, privacy, and availability of technical support. In the subsequent quantitative phase, we collected data from 120 participants using tools like session rating, client scale, treatment credibility expectancy questionnaire, therapeutic alliance scale, and patient satisfaction questionnaire, CSQ-8, to measure the variables like therapeutic competence, treatment credibility, expectancy, psychotherapeutic alliance, and patient satisfaction. So from this mediation analysis, it was found that therapeutic competence had the most influence for patient satisfaction. It directly impacted patient satisfaction. And two other variables, which is treatment credibility expectancy and psychotherapeutic alliance, they parallelly mediated the relationship. So interestingly, while non-clinical factors were also evaluated and valued in the qualitative phase, they did not emerge as significant variables in the statistical model. This discrepancy, I believe, was because people in general usability, it must affect patient satisfaction, but on a more baseline level, direct predictors of satisfaction are therapeutic competence and the expectation people have with the kind of therapy they'll get through a digital platform and the kind of relationship they develop during that therapy session. So I'll conclude it with that patient satisfaction with guided ICBT in Pakistan is influenced by a complex interplay of both clinical and non-clinical factors, and that the findings suggest that a lot of training needs to be focused on the therapists who are delivering the therapy through digital mediums. And along with that, you need to know what your patient preferences and what he expects with the therapy session. That's pretty much it. Thank you. I'm open to any questions.
Thank you so much for sharing. That was super interesting. I'm curious, I know you spoke a bit about why you think those non-clinical factors didn't show up in the quantitative findings. I'm curious how you see that, right? Because we do know that those non-clinical factors are very important still. And I'm curious how you see, right, moving forward, should they, um, how how might that inform how we want to take those into account when looking at digital intervention?
I think a reason for this could be that we need probably to stratify the data and see kind of like if we did it, because the population for this particular study was like all people from urban area, right? They already had access to digital devices. They knew, and they were, the age range was kind of people who were either using Zoom or the digital medium for work or or for like university things and all that. So they were pretty much comfortable with those things. And because the data was collected post COVID time, so a lot of people, I think they have gone used to it. But maybe if we kind of stratified the data and studied it in different age ranges and in like different populations, diverse areas, maybe the picture would be different.
Absolutely. No, that makes a lot of sense. Thank you for sharing and for answering.
Right. If we don't have any other questions, then maybe we can move to the next participant.
Wonderful. Well, thank you, Kanza. Lauren, I think you're up next. So feel free to share screen and get started.
Thank you.
Okay. Hi, everyone. My name is Lauren, and I am a clinical research assistant at McLean Hospital's OCDI. So part of my job is working partially on a phone intervention study, which targets interpretation bias. But the data that I'll be talking about today utilizes the EMA component of that study among patients with OCD. So that consisted of 4 surveys per day for 4 weeks throughout the phone treatment. And as many of you might know, EMA has been widely used as a tool to collect real-time data that may fill in the gaps that result from retrospective interviewing and other traditional data collection measures. So for this project, I was curious to know if EMA could also accurately report OCD insight by comparing EMA or self-reported scores to clinician-reported scores, which were also collected at the beginning of the treatment program. And so for some context, insight is a measure of how aware a patient is of the unreasonableness or excessiveness of their obsessions or compulsions. And I was particularly drawn to this measure just because it is a little bit more subjective. And I wanted to see if this digital medium could help capture that. So what we found after running a Pearson correlation was that there was a positive medium-sized correlation between the self-reported and clinician-reported insight scores, which suggests that EMA might be a valid way of assessing OCD insight moving forward. So with this information, it would be interesting to see if this pattern was sustained over time in addition to just the singular time point that we assessed this comparison. But it is exciting to know that this finding might allow clinicians to create more personalized approaches to ERP by knowing how insight, in addition to other OCD symptoms, might change throughout one day or even a few hours. And also, I want to note that it would be helpful for patients to also kind of get a gauge of how their OCD might change over time, as it might feel a little bit more distressing in the moment and more difficult to see it objectively. And yeah, thank you. I'm open to any questions as well.
I'm curious of how compliant participants were to the EMA surveys.
Yeah, that's a good question. So we actually we removed some participants that either opted out of EMA, but for the most part, we had about a 60% compliance rate with individuals that completed their participation.
You kind of alluded to this, but after the study, were there any interactions with the participants about like the maybe like therapeutic benefit of like logging 4 times a day?
Yeah, so at the end of the 4 weeks, we conduct an exit interview, which I think would also be a cool addition to this type of project. And so in that interview, we asked them how their experience was, whether they enjoyed it or not. And I think there was two main responses just from what I've seen, which was that it's nice to have insight about how their OCD symptoms might change throughout the day. But then at the same time, for some individuals who might struggle more with perfectionism, um, felt a little bit more distressed. So I think in that way, it's also helpful to know how this might personally not work for some people, in comparison to others. Yeah, I can
And
stop screen sharing.
it looks like there's a question in the chat as well. Someone's interested in how you developed the EMA insight question, if you evaluated any reliability metrics.
So I wasn't the person that developed the EMA Insight question, but they were all pretty much drawn from the Y box that we use. So if you see on the left side, that's the EMA Insight measure, which is kind of representative of the Y box, which is the Yale Brown Obsessive Compulsive Scale, which is a clinician rated severity scale. And you can kind of see that the questions are more similar to the ones that we would ask in a traditional interview. Um, in terms of reliability metrics, um, do you mean when comparing the EMA insight score to the clinician rated insight score or among the people that are distributing the interview?
Yeah, so sometimes for EMA, like for the ease of quick administration, we develop a lot of like these I guess self-developed questions without like it's not like a validated measure, even though it is kind of like from a validated measure. Like that happens a lot and it's just a trade-off. But I was just wondering if you looked at like maybe like just user-based, not like with the clinicians, if that makes sense. Thank you.
Mhm. Yeah, that's a good question. I don't have the answer to that question right now, but um, yeah, sorry about that.
Great. Well, thank you so much, Lauren. We can go ahead and move on now. Caitlin is up next if you want to share your screen and get started. And if we have time at the end, we can definitely come back to questions for everyone. Just want to make sure we get to everyone throughout.
Awesome. Thank you so much, Anna. Okay. Can you all see this? Perfect. Okay, great. So hi, everyone. Thanks so much for being here. I'm excited to walk you through this work from the team at Bruin Health. And first, just some quick disclosures. I've received support in the form of salary and or equity from Bruin Health and Otsuka. And I want to emphasize that all views expressed here are my own. So this poster presents a discrete mathematical framework for modeling mental health in a way that that's trying to capture the complexity of biopsychosocial models, and importantly, without relying on black box AI. So we all know, right, mental health symptoms don't come about in isolation. They're the result of a lot of interacting biological, psychological, social factors. And from a research perspective, we've really moved towards these dimensional models, but I think in practice, real world psychiatric assessment still focuses mostly on symptoms. And that's really the gap that this work is trying to bridge. So our approach uses a directed graph-based framework where nodes represent constructs, right? Something like low positive affect or loneliness. Edges represent empirically supported causal, right, relationships or directional relationships. And by encoding these relationships discretely, we can trace individual symptom pathways back to their putative mechanistic contributors and then forwards toward personalized evidence-based treatments that target those specific mechanisms, right? So not just focusing on treating the symptoms. Based on this framework, we developed a software tool for implementation. It starts with patients completing standard validated assessments, something like, the PROMIS depression measures or DSM-5 cross-cutting. Results are scored, matched to kind of symptoms and inferred mechanisms. So for example, if someone endorses depression and anxiety, the system might identify low positive affect and poor sleep as upstream contributors. It then makes recommendations for interventions targeting those mechanisms like behavioral activation, CBTI, and uses LLMs not to make any clinical decisions, but to generate a plain language summary for the PCP and the patient. So we've actually deployed this in real world primary care and in an early clinical validation study. Psychologists rated about 90% of the generated reports as good or excellent quality, right? They'd feel comfortable releasing them as is to the provider without changes. So, very high level here today. The architect of this framework is Andrew DeMichael. He couldn't be here today because he just welcomed his second baby. And fun fact, the company he co-founded a while back, Omada Health, just IPO'd last week. So kind of a wild couple weeks for Andrew. But he has said that he's happy to chat more. His email is here on the poster, andrew@bruinhealth.com. So thanks so much. Happy to take questions here. And again, Andrew would love to dig deeper on the technical stuff if folks reach out. Thank you.
Do you know about like how long of an evaluation or interaction the patient would have at that stage? And I guess what are there aspects or examples of the social piece of it?
Yeah, so the great question, right? So the evaluation it's adaptive. So if someone comes in and is really pretty asymptomatic from like the DSM-5 cross-cutting, for example, those earlier high level kind of screening measures, we don't follow up as deeply versus someone who comes in endorsing, um, you know, potential depression, anxiety, other symptoms, we would screen further and also screen further when it comes to potential mechanisms. So it can last anywhere from like 5 to 40 minutes, I would say, from a time perspective. And in terms of social factors, so, we think about a variety of things. So that could be like social behavior, right? Like loneliness, social support, tangible, emotional. We also think about and measure social determinants of health and kind of those more systemic barriers to care. And then like what we think of as contextual factors like pregnancy or menopause, perimenopause.
I'm curious, sorry if I missed this. Where was it that you were piloting with physicians? What location?
Across the country. So this was actually, it's been it's deployed in upwards of 30 primary care clinics, a mix of, clinic types, sizes, a lot of physician-owned practices right now. And something we're thinking about is how could something like this, or could something like this be useful in more of a like collaborative care model, right, to help with some of the, again, upstream like triage, evaluation, treatment planning at scale.
Very cool. Thank you.
Thanks.
Thank you so much, Caitlin. I had a quick question. Did you share the results back the care plan with the patients ever, and what was their response to that?
Yeah, great. Thanks, Sarah. So we did. So the in the applied version of this, a care plan is generated. That one is PCP facing, one is patient facing, and providers release the patient facing report to the patient. And feedback we've gotten from providers is, I would say, largely positive, right? And the patient facing version, it's all the same information, but a lot more focused on understanding the why, like what do we think is actually contributing to your symptoms with the idea that if patients understand that, the buy-in is there for the treatment. We're not just saying go do CBTI. We're saying like, hey, actually, here's this one thing that we know this treatment targets really well. It seems to be really prevalent for you, so or present for you. So I think that we've gotten kind of positive feedback from the like motivation, trust perspective.
Great. Thank you so much, Caitlin. And again, at the end, if we have extra time, we can open questions back up for everyone. Geneva, if you want to go ahead and share, perfect.
Okay. Hi, everyone. I am Geneva Jonathan, and I'm a clinical research fellow at Massachusetts General Hospital and Harvard Medical School. So just a brief disclosure, the Mindset app that I'm going to be talking about today was financially supported by COA Health, and the research that I'm going to be describing was supported by a NIDA-funded K-12 grant. So today I'm going to talk about transparently describing evidence-based techniques in a smartphone app for depression. As many of you hopefully know, depression affects over 300 million people globally and is a leading cause of disability. Cognitive behavioral therapy is an effective treatment, but many people can't access it due to cost, time, and stigma. Hundreds of smartphone-based tools have been developed in the last decade and are available on Google Play or iOS stores to offer a scalable way to bridge that gap. But many of the available mental health apps don't clearly show what therapeutic content they're delivering. And a recent review, fantastic, and it's linked in the QR code at the bottom of my slide, talks about that many of these apps don't include what core CBT strategies that they are implementing. So of the available depression and anxiety apps, activities like activity scheduling and cognitive restructuring, which are critical to these evidence-based protocols, are either missing or inconsistently applied. So in this study, we examined Mindset, which is an 8-week CBT-based app with weekly therapist check-ins that has shown strong effects on depression severity and quality of life. And so we specifically analyzed how it delivers therapy using 2 frameworks. First, we identify the CBT techniques, strategies like behavioral activation or psychoeducation found in these evidence-based treatment protocols. Then we used Susan Michie's behavior change technique taxonomy to identify the smallest behavior change ingredients like instruction on how to perform a behavior, prompts and cues, and commitment. And so I want you to think of it this way. CBT techniques are what we aim to do. BCTs are how we deliver them. For example, to support behavioral activation, the app might use action planning and verbal persuasion about capability. 3 trained coders, including myself and another clinical psychologist, as well as a research assistant, reviewed each of the 325 unique app pages to identify the CBT and BCT content. Here's what we found. So on the right-hand side of the page is just a very brief overview. We have a paper forthcoming. The app prioritizes psychoeducation and skill building, which together make up about 85% of the content. CBT staples like behavioral activation, cognitive restructuring, and self-monitoring are present but less central, each about 12 to 14% of the app pages. Reflective and maintenance techniques like mindfulness and relapse prevention were used in less than 2% of the content, although I should say that we had these in videos on the app, so it was harder for us to say how much time people were spending on those things. On the behavior side, behavior change side, just 3 behavior change techniques: behavioral rehearsal, instruction on how to perform a behavior, and self-monitoring took up over 95% of the app's delivery. So in summary, Mindset translates CBT into clear, actionable strategies. Users receive very layered support. So every page of the app had multiple CBT techniques as well as behavior change techniques that are implementing those CBT strategies. It's not just isolated skills. And areas like mindfulness and motivation, I should also add social support, may benefit from more structured support in the app. So those are things that we didn't have much of, although I should say that this was just looking at app content. We did not look at how these techniques were applied in the coaching that went with this app. So this kind of mapping can help inform smarter app design and gives us a clearer view of what digital mental health tools are actually doing. Thank you. And also, I should say there's a lot that I was not able to include just for the sake of time. So if you do have other questions, I've included my email at the bottom of this slide, and we're actually submitting a paper on this in just a couple of days.
This is super interesting to see everything laid out and all that you were able to find. I'm curious, you touched a bit on what you would do with this information in the future, and are there any specific avenues that you kind of see yourself, your study team moving forward, or would want another study team to move forward having all of this information laid out?
Sure. Yeah, so identifying behavior change techniques as well as CBT techniques on an app is something that only apps can do, right? So we're not able to really measure that in face-to-face sessions unless we're carefully accounting for time. And so this is kind of the first step that we hope to take in identifying mechanisms. So seeing at what people looked at when they were using the app, seeing what behavior change techniques or CBT strategies were on those pages. And so we can very easily say, here's what people got when they use the app. And if they didn't use these additional modules, they didn't get certain components of the app. And then we can look at, okay, well, this is a first step in knowing what they used. Did they improve or not? And then start to kind of make more conclusions about how these interventions are actually changing depression, how these interventions are actually improving quality of life versus just saying like, we gave them this 400-page intervention, they got better. So we don't really know why. And so the hope for doing this kind of work is to really clearly be transparent about what you're getting and then start to understand why changes happened.
Wonderful. That's very interesting. Thank you so
Mhm.
much.
Thank you, everybody.
And there's a question for you in the chat as well. Someone is wondering if you've considered deploying the app within clinician education pathways as a didactic tool.
Yeah, absolutely. That's a fantastic recommendation. And I think that there's a couple of things going on here. One, our app is really just a mobile implementation of a CBT for depression protocol. So a lot of what you're seeing could essentially translate when you're applying when you're looking at fidelity for CBT, there are metrics to kind of go through a face-to-face session and check off whether or not this actually qualifies as CBT. It's harder to do that with an app, of course, like because it's usually yes or no. And so this is kind of going beyond the yes or no. But what we would hope to do is, in addition to kind of clinician education, this will go back into our educating our coaches, but as a kind of a first step towards clinician education, what we would hope to just do is release this as kind of a protocol, or if a lot of papers in the behavior change space have used Mitchie's protocol, but they haven't necessarily always said how it overlaps with cognitive behavioral therapy. And so we're really pushing for people to start doing that so we can know what's in these apps. I think a lot of people try to gatekeep what are in their apps so that, you know, they own the IP. But let's be honest, CBT for depression is an open protocol book that you can pull off the shelf. So I think that we really should be being more honest and transparent about what are in our unique apps, so that patients know what they're getting, as well as clinicians when they're giving these apps to their patients. Thank you. I don't want to take any more time.
Thank you so much. It looks like you have another question, but perhaps we can take that at the end if we have some additional time for everyone. So now I have Harold next. I don't know, is someone presenting for Harold? I don't know if I see Harold. Okay, so perhaps Malika, if you're up next, if you want to go ahead and maybe if they come later, they can present at the end.
Absolutely. Hi everyone. My name is Malika Saxena. I am a recent graduate of George Washington University's Psychological and Brain Sciences Department, and today's work that I'm presenting is research conducted for our PhD program second year projects. So this study investigated the effectiveness of the Mindfulness Coach app on perceived stress in college students. This app was developed by the U.S. Department of Veteran Affairs, but is available on all major app stores as a resource for anyone who can access. We had 64 participants that did complete our 2-week study, 32 in each group. All participants were current undergraduate students at George Washington University, and the application our experiment group used involved participants engaging in 10 to 15 minutes of daily mindfulness activities. So this included breathing, mindfulness readings, and mindfulness education. Instead of engaging with our app, our control group completed short non-mindfulness related readings each day for the study period. All participants completed a series of baseline and post-test intervention measures, including the 10-item perceived stress scale, which is what we looked at for this poster. In our analysis of pre and post-test measures, we found that the experiment group engaging with the app had significant differences in PSS 10 scores compared to the control group at post-test. There was no significant difference between the two groups at baseline, indicating that the application did have an impact on perceived stress in participants. We concluded that a short 2-week intervention via the Mindfulness Coach app was found to be effective in impacting perceived stress in college students. That's really all. I can take any questions.
I thought it was really interesting that it was only a 2-week treatment period. So I'm wondering exactly why it was so short, kind of the rationale for that.
Yeah, absolutely. So, what we actually wanted to look at was something that would be impactful in a short amount of time. A lot of applications are shown to be effective in a 6 to 8 week or 8 to 10 week time period. This Mindfulness Coach app has a series of levels that you can progress through, and each level is about 2 weeks. So, we wanted to look at the impact of just completing one level, and it is supposed to be a very short intervention, just about, I believe it was a maximum of 14 minutes per day that the level would be that would like whatever activity was assigned to you. So that's why we took a look at this. We wanted to see if it was effective in a shorter amount of time than usual.
Great. And it looks like there's a question in the chat as well. Someone is curious if the app was designed for stress reduction in college students, and also the adherence rate, if you have information on that.
Yeah, absolutely. So the app was not designed for specifically for college students. Like I said, it was developed by the Department of Veteran Affairs, so that was their target population. But we wanted to take a look at it since it was available on the App Store as a resource for college students. And then, as you can see, we did consent 96 participants, but we only had 64 that were adherent enough to be included in our analysis. So that includes anyone who completed 75% of the study. We did have a significantly low adherence rate than what we were hoping for, simply because the study was conducted in the time period between Thanksgiving break and winter break, meaning it was the end of the semester and finals. So that is why we predict that our adherence rate was lower than expected.
Wonderful. Well, thank you so much. And again, we'll have questions at the end if any questions come up for folks. So now I think Allison, you will be presenting if you want to go ahead and share your screen.
Can you guys see that okay? Great. My name is Allison Fetter, and I'm a clinical research coordinator at Massachusetts General Hospital. And I'm excited to share the techniques used by my team in our ongoing online RCT to ensure data integrity. So remote research studies can reach broader, more representative populations, yet they face a high risk of deceptive entries. So the goal of this poster is to share the tiered multi-pronged screening remote RCT that's evaluating a smoking cessation app for people who smoke non-daily. So the first portion I will talk about is the pre-screen process that's detailed in Table 1. If there's a lot of information here, so I'm going to kind of go through it briefly. So first, participants complete a pre-screen form on REDCap, and then REDCap automatically notifies ineligible participants with logic branching. And then during the pre-screen phase, we also screen out duplicate records with data processing via automated scripts using SAS software. So if people are trying to re-enter the study using a similar name.
I'm sorry to interrupt. It's kind of really difficult to hear you.
Oh, it is? Thank you. I'll try to, is this better if I get closer?
It is.
Okay, I appreciate you saying that. Thank you. So I was at the part of the pre-screen process where duplicate records can, sometimes participants fill out more than one record on the pre-screen form. So we use data processing via automated scripts using SAS. So if people are trying to re-enter the study using a similar name, phone number, or email, but are entering different demographics to try to be eligible, we can catch them. And then automatic scripts also help us identify an eligible screen among duplicate cases, but that requires manual study staff review. So then eligible pre-screens who pass these steps detailed in Table 1 are then sent a unique survey link to the screening survey. So now we're moving on to Table 2, and where potential participants who pass the logic branch check questions in the screening survey are directed to provide more sensitive information, such as their mailing address, social security number, and a picture of themselves smoking a cigarette, and a picture of their ID, so we can confirm that the picture of them, the person who's smoking that cigarette, is the same person in that ID, which again requires manual study staff review. So then once participants pass the screening process, they are then finally sent a link to onboard and download their assigned smoking cessation smartphone app. So as you can see, there are a lot of steps that are required to screen out participants, and we collect sensitive information as potential participants move further along in the screening steps. So here we're really trying to balance invasiveness with study staff burden. And in Figure 1, you can see that we had a large number of applications as of May 21st. And in Table 3, it helps to share what steps from Tables 1 and 2 helped out screen cases and the percentage of cases that were screened out. So we were able to screen out more than 50% of entries automatically, and complex cases such as multiple duplicate entries that entered into the study, we required to ask for more sensitive before onboarding to the study. And only about 3.8% of pre-screens passed screening techniques and ultimately onboarded to our study. So some limitations are that this study is still ongoing, and we can never be 100% sure that our screening processes are accurately excluding all ineligible or fraudulent participants, but we do have a lot of processes in place to help ensure that participants can be automatically screened out where possible. Thank you.
Thank you so much for sharing. This was super interesting. I'm curious, and it might be on there. I'm just having a little trouble seeing, but I'm curious if what it was that frequently came to the staff review, where staff were reviewing what frequently came to you all that then you were pushing through and was not, was perhaps caught, but then could have been a throughway for people to still enter the study.
Yeah, thank you for that question. And it probably was a little unclear because there are so many steps that I wanted to get through. But during the pre-screen process, our study staff team will manually review duplicate records that participants can sometimes, we've seen that people enter different phone numbers or emails, but under the same name to try to be eligible for the study. So that requires manual review on our side, but those duplicate batches are identified via automatic scripts, so SAS syntax, that then identifies, okay, this whole bunch of people have the same email or number. and then we sort through those out automatically or manually. And then during the screening process, once participants complete the screening survey, we then review everyone who's taken the survey and who's passed check questions in the survey. So they're like, please answer, agree. And then there are about 5 of them. So participants, once they answer those 5 questions correctly, they're asked to provide their mailing address, social security number, and then provide 2 picture uploads. So a picture of them smoking a cigarette and a picture of their ID. So then we have to manually review those cases, and we get about around 5 to 10 cases a day to review.
Thank you. And do you know what percentage of those that you review end up getting able to go through to the study versus which were kind of accurately caught and prevented from entering the study?
Yes, I'm realizing I stopped screen sharing, so let me re-screen share. So in we had about 10,000 pre-screens, and here you can see that about around like 30% were automatically screened out during the pre-screen process, and then over 50% were screened out again in the pre-screen process. So a good portion of those were ultimately we ended up with only 4% of this 10,000 number.
Thank you so much. And it looks like there's another question in the chat. Someone is curious how you balanced the screening steps versus not asking for too much sensitive information before consent.
Yeah, that was a very difficult process when we tried to see, okay, how much sensitive information can we collect? But fortunately, we don't do like written consent for the study. It is exempt from written consent, where participants just click a bubble in red cap before they start the screening survey that they say, yes, I want to participate in the study. So fortunately that they are agreeing before they provide their like mailing address or social security number, that they do agree to participate in the study before completing that screening survey, if that helps clarify.
Wonderful. Thank you so much. And just double checking, is anyone here to present on behalf of Harold, or is Harold here? Okay, so we have about 6 minutes left if we want to open up to questions for everyone again, if someone didn't get to ask a question or kind of came up with a question after listening to others. Geneva, I know you also were able to respond to a question in the chat, but if you want, do you want the opportunity to share more? I know we were kind of
I can
pausing that,
briefly
but
just say that what I would do, and to explain this clearly, what I would do is measure. There are some really great determinant surveys that go with Susan Michie's work that look to when you're identifying a behavior change technique, it's usually associated with the behavior itself. And so you can measure what changes in beliefs happen with participants to measure whether or not the techniques actually did what they were supposed to do in terms of implementing skills. The other way that I think that all digital mental health interventions need to be evaluating their success is by actually figuring out ways to measure skills practice. So for example, in our mindset intervention, we looked at whether or not people were actually doing the activity scheduling that's really important to CBT for depression, meaning that they were like picking out activities that they were going to do to get them out of the house. And we found that like not many people were putting it into the app. And so the next step would then be, well, did you do it? Most people might probably say yes, but we need to figure out ways to monitor skills used generally. So one way you can do that is measure changes in beliefs, but the other way that you might do that is incorporating wearables to kind of monitor skills practice. Although I'll say that we haven't yet even looked at how wearables can monitor a skills practice. We're only really just figuring out how they can follow symptom severity and remote monitoring. So that's just an idea there. So I would say right now, just using basic measures.
Thank you for elaborating on that a bit more and explaining. Any other questions in our last 4 minutes here? All right. Well, thank you everyone for joining. Thank you to all of our presenters. This was very interesting and a wonderful lens to look at all of these different posters and what we can learn from them. So thank you all very much for presenting and everyone for joining and asking questions. Have a wonderful rest of your Tuesday.
Thanks so much.
Thank you.